Dr. Umar Zubair to tell us all about patellofemoral arthroplasty, indications, and outcomes.
Bismillahirrahmanirrahim. Right. So we have replaced the medial knee, the lateral sided. I think the only part of the knee left is the pat fem. So let's see what we can do with it. So the only disclosure I have is that I've done the Zimmer Fellowship from Southampton, but nothing much. A little case for you guys. We got a 46-year-old female who has been referred to you by one of your friends having a long-standing anterior knee pain and stiffness. He has tried everything, injections, painkillers. She's fit and well otherwise. Quite reasonably BMI with 30. Examination-wise, knees swollen. There are quite a lot of patellar crepitus. Limb alignment looks good, and these are her x-rays. What would you offer? Any ideas, any thoughts? No. Well, I think there must be some ideas and thoughts in your minds, but you won't be agreeing that what would you offer. But I think at least one thing is there that you will all agree to is she has got a PATFAM OA. This is something which now is getting more and more popularity among us as knee surgeons. A lot of studies have shown that the incidence of isolated PATFAM OA is much more than we thought. About 10% of people over 40 years of age, predominantly female, and most of them would have, at least 2/3 of them would have a feature suggesting of instability during their early phase of their life, or PATFAM dysplasias, or they just simply have anterior knee pain without any of these factors. At least 33% of these people haven't got any issues, but they have. And another very interesting fact is that it is very commonly found in Asians and Middle Eastern people. The studies which I found were one from China and the other one was from Turkey. Usually all have got pain, abnormal Q angles, or at least most of them have. J signs will be positive. Quadriceps weakness is another interesting fact. And along with that, few other things, which is like hamstring tightness, and you will find them to be a straight knee walker, or some of them are straight hip walkers. We'll come to this at some other point. Now, so I would simplify for you guys. Now, we know that this patient has got patello-femoral OA, and she has come to you with a failed surgical management. She's between 40 and 60 years of age. Her BMI is less than 30. She has got a patellar instability background, trochlears B or D. ANCs don't come with these problems often. Or she has got an unexplained idiopathic anterior knee pain with no fixed flexion deformity, or I'll give it a levi of like 5 degrees, valgus, varus, no inflammatory arthritis, no infection, no CRPS, nothing is there. You have done all these x-rays, and there's a reason why we have done the AP, the lateral, the Rosenberg, the merchant view. Limb length looks good. Or if you want to do the CT and MR scan, what would you do now? Okay, I'll do a PATFAM replacement on her. So just for recapitulation, Avano classification not very frequently used. Type stage 1, 2, 3, and 4. As we know that the narrowest part of the PATFAM joint space is less than 3 millimeter, or then it starts going more than 3 and no space left, and it's progressive from stage 1 to stage 4. Now let's talk about the PATFAM evolution. This is the implant, which I would still say it's in the evolution process. We still are in the infancy period, even in the Western Hemisphere. And the first, or the very first earlier implants from the 1950s was the Duncan McKeever. This was basically a Vitellium prosthesis, which was kind of a resurfacing for the patellar fractures. A lot of people after the 40s and 50s were people were not fixing the patellas. Either they were fixed badly or they were just having the removal of patella altogether. And for obvious reasons, these implants didn't work very well, and they started to fail. In the 1970s, people thought about changing not only the trochlea but the patella as well, and they started bringing these kinds of newer generation, the Richards II or the Lubines, which had slightly better results, but still not very happy. The second generation was better in the sense that they have anatomic cuts, the PFJ kinematics were reproduced, or they thought that we have reproduced the kinematics. Like FPV has from the right medics, or A1, again, one of the earlier generation implant from the second generation point of view, or the Journey, Smith & Nephew, that's the A1 and the Journey implants. Then came the third generation, the 1990s, PFJ gender solution, the Zimmer. This is the one that I have used with my boss in my unit, and we have got a reasonably sized study on it as well. That's the Zimmer implant, though there are other implants available which are equally good, Sigma, Journey, or the Kinetic. So what's so special about this third generation now? As we evolved, as we started to know more and more about the kinematics of the PFJ, we started doing the appropriately sized, the appropriate radius of curvature was started to be put in the sagittal planes, and more broader range of medial-lateral coverage available. In the earlier implants, that was not the case, so you were quite stuck. Either you do it or you don't do it. And they started to bring it slightly proximally, and the lateral edge was thinned out, maximum 5 millimeter thickness, no more than that. And there's a reason, we'll come to it at a later point, that why is that important. And especially the Zimmer ones, they believe that we have recreated, according to the gender, the anatomical sulcus angle. Just a quick picture for you guys to have a look at how the radius of curvature slightly differed on the lateral views of the A1, which was again second generation because it was only to the gender solution, the Zimmer one. Now, because it's something which most of us don't do it very often, and I believe in this part of the world is, as far as I know, it's not been done. I have spoken with some of my colleagues. Standard knee approach, midline incision, is a debate, medial or lateral arthrotomy. In our series, we did all with our medial sided, though I know people are doing it through the lateral side as well, because it's mainly lateral facet disease, and they say that it's a bit difficult to go to the lateral side if you are approaching the joint from the medial side. And again, if there is some, because of these patello-femoral dysplasias or instability, the lateral sides are sometimes contracted and you have to release them. You do a medial-sided arthrotomy, you do a release of the lateral side, so you have kind of taken the blood supply off from the patella. The most important bit, the exposure. Do not hesitate from top to bottom. You have to have a nice, decent exposure. And but like we always did the denervation, just like standard knee replacement, though some people don't believe in it, but we were using the diathermy to go around the patella to denervate it. If need be, we were doing the fascectomies as well, but making sure that the minimum width we are left with is 26 millimeter, and a minimum of 14 millimeter thickness is there. Now, this is the most important bit, because patellar preparation is not that difficult. It's kind of just like a standard total knee preparation, where you have a bit of levi to do either slightly medialization or distalization according to the need. But the trochlear bit is the main thing in the PAT-FEM outcome, and that is something which we have found over the years, that how does it make a difference. Again, while doing the preparation, medial-lateral marginal and the spur clearance is very important. That's the same spur that we see on the lateral views, which is the spur sign. So you have to clear them off. White side line identification, not very easy, especially with trochlear dysplasias, but you can definitely go for the transepigundular axis easily, draw it, use the IM instrumentation, Anterior femoral cut, that's the main thing. It has to be laterally tilted about 10 degrees, though it's the jig based now, but still you have to make sure that you have to put the jig appropriately, and it has to be laterally tilted with slight posterior tilt. Why we are doing all this? We are actually trying to reduce the TTTG distance here, and we are trying to marry the patella with the trochlea. So, yeah, as we said earlier, the trochlear component, the lateral side, should not be too thick. The earlier implants, they were quite bulky. People were putting them a bit proud. Anterior compartment was overstuffed. People used to come back with anterior knee pains. And that was one of the prime reasons for conversion into the total knees. But if you have got a trochlear component which is put appropriately, and there is no stepping off from the lateral condylar, from the lateral aspect of the implant to the lateral condylar cartilage, that is the best thing to have. Appropriate sizing, now again, we have got a wide variety available, which was not there 20 years ago. And the distal chamfer cut is now again jig based. We'll have a picture of it in the coming years. The drill studs, trial, patellar button preparation, standardized. You can, as I said, always try to play around with it if need be. You can medialize it or distalize it according to the need. Now, that's the slight lateral tilt, and we can see that how the lateral rotation of the femoral anterior cut, it brings the TTD distance to slightly smaller, and that few millimeter reduction in the distance is the key. Now, another aspect, whenever we put this implant, the proximal bit, starting from the proximal bit, has to be in valgus, and that promotes the smooth transition from flexion, from extension to the flexion, so an easy engagement, hence minimum pressure effect on the PFJ. And as we know that the more pressure you put on the anterior compartment, it all gets transferred to the medial side. And that's a second most common reason for the revisions, progression of the disease from anterior compartment to the medial compartment. So soft tissue balancing is mainly a soft tissue balancing surgery. We want to put the implant in it, no doubt, but it has to be as less strained as possible. Again, whenever you are doing this through any approach, whichever you are comfortable with, and the key extension is the key point is the extensor mechanism realignment. Total time is us. I'll go a bit quickly here now. These are a few of the pictures that we have done in Warwick, and we published this as well. These are our results from 2017, which we published, me and another fellow. We did about like 50 patients. We followed them up for 40 months. Good scores. Mean survival was about 8 years. Pain and disease progression was the main reason of failure or conversion. Now, if you start looking into the literature, you won't find many papers, but there's a plethora of the papers saying that it works. You can look at loads and loads of papers, but the game changer, I believe, was this from 2021 from US, which was a systemic review with meta-analysis, where they have confirmed that the onlay implants, they, at least from short to mid-term, they work quite well. And that's just an overview of what they found the results are. Again, to do PAT-FEM replacement, one must be fully aware of how it happens and how we can correct it. I would highly recommend David DeJoe's book, and that's the chapter from that, which we all, if we want to do a PFJ, we were told you need to know this chapter in and out. Young anterior knee pain, don't push them away, because they will come back to you. If not in 5 years' time or 10 years' time, in 20 years' time, they will come back. Isolated PFGOA, do consider replacement. So act early. Patient selection is the most important bit. And whenever you are cutting, cut meticulously. Be careful. Don't overcut or even undercut, and you will be fine. Thank you.